Hi, this is Dr. Subramaniyam here. I'm going to help you through this session, wherein which by the end of the session I feel everyone will be empowered to use this powerful tool known as gastric ultrasound in your practice. Whether all the anesthesia societies in the world, whether it is our ISA or ASA, we have come out with the guidelines. When is the last patient who is scheduled for surgery and anesthesia can have something to eat or drink? These are the standard guidelines which we follow. What are these based on? It is generally based on the scintigraphic studies. How long does the stomach take to empty? These have been studied religiously, and we have an idea that it's probably going to take such a time. But what happens in practice is nearly 5% of the patients may not follow the NPO guidelines properly. And some of them, in spite of fasting, may have at least 10% of the contents in the stomach still there when they are scheduled for surgery or anesthesia. And this poses an extremely important risk for us, what is known as aspiration. Now, if you notice, a few years back, around 5 years back, our ISA came out with a guideline saying what is the role of gastric ultrasonography in assessing patients. It says that you can use it to see the stomach and assess what is there in the stomach. Now, why do we need to learn about gastric ultrasound? The fundamental reason being, if you are assured is the stomach empty, then proceed as planned. You don't need to do anything. But in case if you're not sure, then by the end of the session, I want everyone to pick up which part of the stomach we should scan. And when we scan, it's possible to identify whether the stomach has solids, liquids, or it is empty. And accordingly, we can plan our anesthesia, plan our airway in such a way that the patients are safe when we give anesthesia. Now, as we go through, I want to go through in these steps. Why should we use gastric ultrasound? How to perform a gastric ultrasound? How to assess the contents of the gastric and content in the stomach? What is the structured way of assessing the risk? And can we use it in children and pregnant women? And what is the framework under which we can use it? And how good a powerful point of care tool is it? Now, in the past, whenever we had to assess whether the patient's stomach is empty, was purely based on patient's word and background medical conditions. For example, which emergency surgery, we thought it probably is a full stomach. All these were passive ways of assessing. In this modern era, when we have the powerful tool known as ultrasound machines, which are as good as like a powerful laptop and portable, we can objectively assess the stomach and see what is happening, what is there in the contents. Now, the reason being, many of our patients who come for surgery have these chronic diseases. And all these diseases, they delay the gastric emptying. As a result, patients, even after fasting for a recommended 6 to 8 hours duration, their stomach might still have contents and pose a significant risk for aspiration when they are being induced for anesthesia. Along with that, we have patients who come with pain and trauma, which delays the gastric emptying. If you thought that was enough, you can see these are all the various drugs which can cause delay in the gastric emptying. So as a result, a significant number of patients who come for anesthesia and surgery may have stomach which is still has contents in it and can pose risk for aspiration. Now, what do we need? Any of these portable ultrasound machines, if you have, it can be used to perform gastric ultrasound. Now, when we perform gastric ultrasound, which part of the stomach we look at? We are mainly trying to focus on the pyloric antrum or gastric antrum, because that is a particular area of the stomach which can be easily identifiable, and there is a significant reason as well, because it is easy to identify because it is sandwiched between the anteabdominal wall and the stomach. So these are the structures which you will see as we go through. And also the reason is it is possible to identify the gastric antrum because it has got a characteristic appearance compared to any other part of the gastrointestinal tract. So it got a typical 5-layered appearance which can be identified in majority of the individuals. We are not looking at fundus, we are not trying to look at body because it can have lot of air and cause lot of misinterpretation. We are trying to look at antrum. Now, so it's essentially what we do when we do gastric ultrasound on a patient who is lying flat. We try to identify just space below the xiphisternum, start up slightly to the left of the median and slowly move towards the right. Till when? Till we cross the aorta. I will show you how now. So this is what is happening deeply. So it moves from slightly to the left, to the right, and where we identify the gastric antrum. Now what kind of transducer setting we need? Normally in most of the adults we require a curved transducer, whereas in children you probably can manage with a linear transducer as well, and it may give you a very high resolution picture. Generally it is said, it is practiced that we should do gastric ultrasound in 2 positions, that is in supine and right lateral positions. In case if somebody is not able to turn to right lateral, you can give a slight head up and take a graph as well. But it is very useful for quantitative and semi-quantitative, may not be useful for quantitative assessment. Okay, you can use it for qualitative and semi-quantitative, not for quantitative assessment. It's not validated. Now, when you put the ultrasound in that area, epigastric area, this is what the picture what you get most of the time, a lot of grays and whites. But if you carefully follow, identify the important structures, you will be able to identify each and every structure what is there in your images. If you start from skin there, that is the skin, subcutaneous tissue, there you can see the layer of muscle, the rectus sheath muscles. The big thing there on your left hand side is your liver and the pulsating aorta, the superior mesenteric artery, and you can see the large bowel shadow there sometimes, and sandwiched between the liver and the duodenum pancreas will be our gastric antrum. Now again the same picture which we saw before, if you look at now, you can pinpoint, you can put your finger there where the stomach is there, isn't it, right? Okay, now when we do assessment of gastric contents, it is recommended, or we follow a 3-step pattern. So you can say you can do a qualitative assessment, semi-quantitative and quantitative. Qualitative means we are looking at to say that whether it's like expressing a quality. For example, somebody is good or bad, or tall or short. In this qualitative, what we mean to see is we want to see the stomach and say whether it is empty or got liquids or solids. Okay, semi-quantitative means it is not quantifying how much is there, but it is semi-quantitative, so it's approximately full. In that way we can say. Okay, quantitative means we are exactly measuring what is the amount of residual contents in the stomach. That is what we are trying to do in a quantitative assessment. Well, how to do these assessments we'll go through slowly. Okay, now the first thing is qualitative assessment. In the qualitative assessment, you do take the image in standard positions and identify whether the stomach is empty or not. Now you take a picture, freeze the image and have a close look, identify the pattern and say whether it is empty or not. It could be filled with liquid, isn't it? So if it's filled with liquid, this is the kind of picture you will get when you have the stomach contains liquids, especially clear fluids. But if it contains solid, this is the kind of picture what you will have, semi-solid or solid. So qualitative assessment means you can have 3 kinds of picture. One is empty, the second one is liquids or semi-solids. This is the qualitative assessments we talked about. Okay, you can have, it can be empty, it can be filled with solids or semi-solids and clear fluid. The next kind of assessment is known as semi-quantitative assessment. Here we are not looking at the character, we are looking more at the quantity what is there in supine and right lateral position. What do you do in this? In this, the assessment has to be done in 2 positions, supine and right lateral. Okay, if solids are there or thick fluids are there at any point of time, it shows that the risk is high and it is not safe to proceed. But in case if you find it is empty in the supine position, turn them to right lateral. and see if the clear fluid is there only in the right lateral or in both supine and right lateral. If it is there only in the right lateral position, it is likely that the fluids, the residual content in the stomach is likely to be less than 100 ml. That means it is safe to proceed. But if you find there is some fluid both in the supine as well as in the right lateral decubitors, that means the residual content is likely to be more than 100 ml. So that means the risk of aspiration is high. Okay, that is the semi-quantitative assessment. Now, quantitative means you are exactly estimating. For example, what is your height? If you ask, 175 centimeters. What is your weight? 75 kgs. So in that way, here we are trying to quantify exactly. Okay. Now, people have worked on this to identify, they have developed equations, algorithms to exactly estimate what is the residual content in the stomach. This is usually, or most of this work has been happened around when the liquids are there. At any point the solids are there, your assessment says solids means it's a high risk for aspiration. If aspiration happens, the outcomes can be quite worse. Okay. Now, so when we do quantitative assessment, what people are trying to do is, first is identify the stomach, identify the gastric antrum, freeze the image and take out the cross-sectional surface area. Once you have the cross-sectional surface area, the people from Toronto, especially Anahi Parlas, etc., they have given this equation, which have used it extensively, wherein which you can easily put those things along with the age, so you can estimate the actual volume which is there in the stomach. This has been validated in adults, also in children nowadays, so to estimate the residual content. They have also given a chart according to age, which one is safe zone, which is not safe zone. Okay, all those less than 100 ml here in the adults is considered as safe zone, residual volume. Okay, you can also develop your own ingenious way, an Excel sheet, wherein which you can estimate, enter those parameters. You have a hands-on feel of how much is the residual volume. Okay, now now how to freeze and estimate? What you do is, once you identify the stomach which is filled with the contents, with the gastric antrum, there you freeze the image and then you take out the cross-sectional surface area. Okay, so you might measure the take out the circumference and measure the cross-sectional surface area. Once you get this cross-sectional surface area, if you put those into the equation, you will get the residual contents. Okay, so what is the formula? You can see here the formula is mentioned at the top there. That formula, if you can use, you can estimate the residual volume. Now, what is the importance of this volume? If the volume of the contents in the stomach is more than 1.5 ml per kg, it is generally considered as higher risk for aspiration. If the volume is less than 1.5 ml per kg, it probably is safe to proceed, but you may have to take precautions depending on what other comorbidities patient has. Okay. Now, in summary, when you want to do gastric ultrasound to assess the content of the stomach, there are three types of assessments. First is qualitative assessment. Qualitative means you are looking at the picture and deciding whether it is empty or it has got solids or liquids. If it is empty, safe to proceed. Clear fluids, if it is there only in the right lateral, safe to proceed. At any point of time, if you find solids are there in the stomach, it is usually considered as high risk. Now, the semi-quantitative is you do it in two positions. Fluid present only in the right lateral, it is probably safe to proceed. Fluids in both supine and right lateral, it is not safe to proceed without any adequate precautions. If you want to estimate, if you want to publish, etc., you can go ahead and do a quantitative assessment to check what is the residual volume of the contents in the stomach. Okay, anything more than 1.5 ml per kg of residual content in the stomach is considered as high risk. Less than 1.5 is probably safe to proceed. Can it be used in children? Yes, people have worked on it and they have given an equation how to estimate the liquid contents in the stomach. Okay. Is it applicable in, how does it look in a 1-year-old? This is probably a typical appearance what you get in a 1-year-old child. You can see all the 5-layered appearance of the gastric antrum here. Okay. Now, what about in pregnant ladies? Yes, people have come out and given an equation. There are two kinds of equation. One is measuring the cross-sectional surface area. Other one is also with measurement of the two diameters at different places to estimate the gastric volume in the pregnant ladies. Now, that is about the assessment. Now before I finish, I want to tell you a few things about this. One is, of all the uses of bedside gastric ultrasound, gastric ultrasound is a wonderful way of using it. It is, it serves all the purpose of a powerful point of care tool. One is, does it have a well-defined purpose? Yes. Is it focused and goal-oriented? Yes. Findings, can it be easily recognized by everyone? With a proper training, everyone can recognize the stomach, everyone can recognize the contents in the stomach. Okay. The examination can be easily learned and quickly performed at the patient bedside and improves the outcomes. Now, how to use this? Now, a framework has been given how to use this gastric ultrasound as a bedside tool. This framework is generally applicable for across all the point of care tools. Here, this is called as IAM protocol. What does IAM stand for? I stands for indication, A for acquisition, I for interpretation, and M for medical decision making. So here, the indication is whenever there is a doubt whether the patient has been NPO or not, you suspect some emergency content is there in the stomach or not, you can put your probe and know what is happening. It can also be done when somebody is unable to communicate, somebody with a trauma, or somebody with unconscious. So all these cases you can check in whether the stomach has contents or not adequately. Then it helps you in the planning of the airway. Now, acquisition. Now all the while what I talked about was acquisition of proper images. The most useful position, if you want to take one view, is right lateral. The best thing is to do acquire images in supine and right lateral and go through the stepwise assessment. Now, interpretation, we talked about how to interpret, how to do a qualitative interpretation, how to do a quantitative interpretation. Okay. Now, decision making. Now comes the important thing. Depending on what we find, we can plan whether the anesthesia we should continue or not. If we continue, what steps we can take to prevent the aspiration. Okay. So now it is not about cancelling a patient, it is about helping us choose the appropriate technique for the patient. Okay. In case if there are some stomach contents, you may want to decide to wait before you proceed. If you want to proceed, you have choices of giving RA or general anesthesia. If you want to proceed with general anesthesia still, then you can take adequate precautions to ensure that the aspiration chances are minimal. Okay. Before I complete, these are some very good images for you to take home, review at your own time, and understand how the stomach looks like. This is the gastric ultrasound when the stomach is completely empty. The two walls of the gastric antrum is completely opposed to each other and giving a target shaped appearance. There may be a small bubble of air which comes and goes. Okay, that is in the empty stomach. If you have clear fluid with, sometimes mixed with air, you can get a starry sky appearance like this. Now what you can also get is, in case of late digestion, somebody has eaten a little bit of biscuit, etc., you can kind of this frosted glass appearance. Okay. Now this is the appearance of the stomach in a 1-year-old child, where you can appreciate all the 5 layers of the the pyloric antrum. So now this is again another sequence of image. I am sure you will appreciate it. I had asked one of my colleagues to come with an empty stomach, and we scanned sequentially to see how it looks like. This is the image when a volunteer had come fasting for more than 8 hours. You can see, you can identify the pyloric antrum there. This is in supine position. There are minimal contents are there. Maybe a little bit with peristalsis is coming up there. But the same volunteer, when it was turned to right lateral, you can clearly see there is some increase in the contents there. small amount of content is coming with every peristaltic movement. This is a normal finding. This is not abnormal at all. Small amount of liquid when patient is turned lateral is probably, you will find some amount of liquid. Now, after giving a drink, you can see the stomach has expanded, pyloric antrum has expanded, and you can see the walls as well as the circumference around it. Now, after giving a carbohydrate drink, which we give pre-carbohydrate drink, so you can see the stomach slightly different from that, but you can clearly see the dilated stomach is almost like a clear liquid as well. Okay, after turning right lateral, you can see the contents of the stomach has increased in size, and little bit of air patients usually take up along with the liquid. Now here, after 5 minutes of turning right lateral, you can see all the contents are there in the pyloric antrum and looks big. If you want to estimate, this is a good time to estimate. Okay, now after a meal is given, you can see the antrum, how appearance has changed. When it is liquid, clear liquid, it used to allow all the ultrasound beam. Here there is a mixed echogenicity is there. The stomach is dilated, and a lot of various digested contents are there in the stomach. Okay, you can clearly see there right lateral with peristalsis, some part of the content is moving, mixed with liquids and solids. It's more like a dough which is moving with peristalsis. Okay, now we saw all those pictures there. We went through that gastric ultrasound is a powerful point of care tool. So it gives us, with it we can do a focused and goal directed assessment. It can determine the gastric contents, and we can assess what is the aspiration risk. It can help us guide how to manage the airway if we want to proceed, and very easy to learn and can be used in all age groups, and it's fairly accurate and reliable. So now it is left to you now. You have heard up from me, so you can start using an ultrasound in case if you are in doubt, or if you want to contact me. Here are the details, and good luck practicing gastric ultrasound, and have a wonderful time. Thank you.